Hi, my name is Alexandra Boyd, and I'll be presenting the incidence of subclinical infection in patients undergoing revision shoulder stabilization surgery, a retrospective chart review. Dr. Itamura and our team have no financial disclosures to report. As our understanding of shoulder instability and options for treatment grow, it remains a common yet difficult problem for surgeons to tackle. There are numerous complications that can impact the postoperative clinical course and potentially lead to failure, and those are non-union, recurrent dislocation, nerve injury, thrombosis, and infection. Although the less than 3.4% rate of shoulder infection after arthroscopic or shoulder surgery is relatively small, it is significant enough to halt the healing process of a large subset of patients. Purulent infections of the shoulder typically present with fever, drainage, swelling, elevated erythrocyte sedimentation rate, and C-reactive protein values. Unlike the hip and knee, shoulder infections are commonly low virulent in nature and have an asymptomatic or subclinical immune response, along with normal laboratory inflammatory markers. The most common cause of shoulder infections is Cutibacterium acnes or C. acnes, previously known as Propionibacterium acnes or P. acnes. And C. acnes is a gram-positive, low-virulence, aerophilic anaerobic rod found deep in the pilosebaceous glands of sebum-rich areas like the shoulder, neck, chest, and back. Despite thorough surgical prep, it is very difficult to remove C. acnes from the skin flora, and surgical incisions can introduce this bacteria into deeper levels of the dermis. In addition, C. acnes has a long incubation period, usually held for 10 to 21 days. And this is because it has a slow growth rate in addition to taking a long time to be stained and detected. This means that surgeons and patients have to wait weeks sometimes in order to find results of their shoulder collection. C. acnes is also an indolent bacteria that does not form pus and presents as a clear fluid that is very similar to normal wound drainage. Therefore, the low virulence, vague clinical presentation, and the longer incubation period of C. acnes makes shoulder infections very difficult to diagnose. And providers who try to complete a thorough infection workup must also keep in mind that, unique to shoulder surgery, commonly used diagnostic labs are not accurate and do not provide their normal clinical utility here. Routine standard of care for shoulder stabilization surgeries does not typically include infection workup unless clinically suspected. However, given the nature of the infections of the shoulder, infection workup thoroughly should be involved and at least considered in the preoperative protocol for patients. Therefore, the study primarily looks to identify the incidence of subclinical infection in patients undergoing revision shoulder stabilization surgery, and secondarily to identify any risk factors for developing these subclinical infections. Patients with previous bony or soft tissue revision surgery undergoing open or arthroscopic revision with the senior author were included, regardless of age, number of previous corticosteroid injections, or number of previous surgeries. Patients with previous infection or with incomplete chart documentation of a previous infection or no surgery previously were excluded. 124 charts were reviewed to fit these criteria, and 107 of these patients met criteria, 84 of those being male and 23 of those being female, with an average age of 35.12 years. The 2018 periprosthetic joint infection criteria, or PJI criteria, which is usually used in revision shoulder arthroplasty, was applied here and used to decipher the clinical value of multiple positive cultures. Of the 124 patients included, 107 met inclusion and exclusion criteria, and we reviewed each patient's demographics, including gender, race, and status of smoking, and found that no risk factors were significantly correlated with development of subclinical infection. 29 patients of 107 had positive cultures. 26 of those had positive C. acnes cultures, and one patient had both Candida parapilopsis and C. acnes. 15 patients, or 14%, had 2 or more cultures of C. acnes isolated. There was no statistically significant differences in infection incidence rates between these groups. Identification of non-purulent, non-virulent organisms that infect the shoulder is incredibly difficult. There's no current standard diagnostic infection criteria for arthroscopic shoulder procedures. However, the 2018 PJI criteria, or periprosthetic joint infection criteria mentioned earlier, can be applied here, although it is usually used for shoulder arthroplasty. There's debate over the clinical value of one positive culture, but the PJI criteria chart shows that 2 positive cultures has a specificity of 100%, sensitivity of 95%, and accuracy of 97.5%. From the cultures taken in our study, 14% of patients had 2 or more positive cultures from C. acnes. This indicates a definite infection according to PJI infection criteria and a serious, often asymptomatic clinical problem for surgeons to solve. Shoulder stabilization surgeries are common, and most of them, revision or not, are not cultured unless infection is indicated or a purulent organism is present. However, Dr. Itamura, the senior author, is well aware of how elusive certain bacteria can be, like C. acnes, to detection, and therefore makes it a point to take cultures on everything and to send patients home with antibiotics. The main limitation of this study was that it was underpowered, which could have contributed to the lack of statistically significant risk factors in contrast to previous studies. However, there must be further investigation on hirsute individuals, typically men with more hair, and this means more pilosebaceous glands capable of housing C. acnes infection. In addition, smoking has been previously identified as a risk factor. Dr. Itamura largely refuses to operate on smokers. And lastly, the length of time between the initial procedure and the revision procedure should be considered, as C. acnes is very slow growing. Previous studies explore clinically suspected purulent infections, while our study explores the subclinical infection rate in all patients, even when there are no clinical signs of infection. The study ultimately shows that in all of Dr. Itamura's shoulder stabilization revision cases, 14% of them had a definite infection that would go otherwise undetected if the full infection workup was not completed. Therefore, infection workup should be addressed regardless of clinical presentation. And given the long incubation period and non-purulence of these C. acnes shoulder infections, surgeons must be consistently aware of the possibility of a C. acnes infection and should be sending patients home with antibiotics while also considering ways to improve their own surgical protocols in order to eliminate the pathogenic risks to their patients. Therefore, regardless of clinical presentation, optimization of patient care for those undergoing shoulder stabilization surgery requires thorough infection workup and postoperative antibiotics. Thank you.